This first slide shows the outline of the course, which is in 4 parts. In part 1, I'm going to talk generally about the kind of context in which we're thinking of introducing ICTs into the health sector, some of the kinds of applications that people have suggested. In part 2, I'll look at 4 specific areas of application and try to examine in detail some of the benefits and costs that might arise in each of these areas. In part 3, I'm going to look at a topic which is currently very much on the development agenda, which is around chronic illness and the role of ICTs in the self-management of chronic illness. And in part 4, I'll look at the potential relevance of those ideas around self-management in resource-poor contexts. Just to quickly indicate the kind of healthcare context in which we're thinking of introducing ICTs, typically there will be complex health markets with lots of people who are offering to provide you with health services. Typically they will be selling you those services. We often refer to a cash for services situation, even for those people who say they are working in the public sector, and many people will be working in the public and private sectors simultaneously. One thing which is often not mentioned is that even in resource-poor areas there is a wide diversity of health needs. So the ones that are typically talked about are preventive services such as immunization, prenatal care and so on, and then primary curative healthcare services where you have a fever and want to get a tablet from the doctor. Less commonly talked about are the needs for referral services. If I have a serious illness, then I do want some way of getting a referral to a hospital, a higher level health provider. Very little is said about chronic illness management. Lots of people live with long-term chronic illnesses and often don't have a diagnosis and very little treatment. And very little palliative care for the elderly sick, for example. Palliative care may consist of some aspirins or paracetamol. When we talk about multiple healthcare providers, well, we know that not a lot of doctors, nurses, midwives and pharmacists are prepared to live for long periods of time in resource-poor areas, in the poorest areas of countries. In the rural areas of countries, they want to live in towns where they can send their children to school and where their wives can get jobs and so on and so forth. Typically, the context I'm thinking of is where there's an absence of high-level accredited providers, either in the public or private sector. So in terms of people with, as it were, a license, accredited providers, the reliance is on low-level extension workers, community health workers, village health workers. They have different names in different countries, but they're basically people with maybe 3 months training, maybe 6 months training, who have accredited status to undertake relatively simple healthcare tasks. Most care in these environments is, of course, provided by unaccredited providers. So we refer to UAPs, unqualified allopathic practitioners. These are people who provide so-called Western medicine, standard drugs that you would find in most countries. You can also go to drug sellers working in markets or in local shops to buy your drugs, or you can go to a whole range of alternative, traditional and faith healers, religious healers and so on. China, for example, where I work quite a lot, people will go to the village doctor and they may buy allopathic medicines which are stored in one cupboard in the clinic, or they may buy Chinese traditional medicines which are stored in another cupboard. The village doctor doesn't mind which of the two you purchase. In fact, it's probably an advantage to the village doctor if you buy the traditional medicines which he's probably prepared himself. The important thing about this slide is that it indicates that we need to think fairly carefully about who is going to use the technology that we're introducing. In rural Bangladesh, for example, about 80% of healthcare is provided by village doctors. Now, are we going to exclude them from the use of our ICT innovation, or are we going to try to persuade them to come and join us in helping to solve the healthcare problems of their populations by using the technology? The view of myself and my colleagues is that in this kind of environment, the traditional way that people think about a health system, what I've described here as an integrated network of organisations and institutions delivering preventive diagnostic and treatment services under a strict regulatory rule enforced by government, doesn't really apply. This is not what people are dealing with. And so we've tried to adopt a more generic way of thinking about health systems which actually matches the situation on the ground. So we're saying here ways of organising access to expert knowledge embedded in both people and products. So the knowledge might be in a drug, it might be in a piece of equipment, it might be in a computer algorithm on a smartphone. And we see the health system as one in which multiple types of power relations are embedded. There are lots of actors in these health systems. all the different types of providers that I've mentioned, the patients themselves, their carers, their families, their communities, politicians, health officials, and so on. And lots of different power relationships between those actors that determine whether an intervention will succeed or fail. And we refer to this approach as health knowledge economy because we focus attention on the stocks and flows of health knowledge. Well, the flow of health knowledge is information, and we're dealing here with information and communications technologies. So we're interested in how health knowledge is valued, who decides what is valuable health knowledge and what is not valuable health knowledge, who possesses different types of health knowledge, and how do people gain access to that knowledge. So what are the potential impacts of ICT innovations on the health knowledge economy? Well, I think there are two broad effects that one might expect to see. On the one hand, the new technologies might reinforce and extend the existing mechanisms for knowledge management and exchange. So, for example, we could use mobile phones to collect routine data from health clinics. We could introduce computerization to manage drug purchase and distribution. We could set up databases for clinical records and so on. So all ways of, if you like, improving the quality of the existing healthcare system. On the other hand, some ICT interventions might introduce fairly radical changes into the way the healthcare system is organized. For example, patients might bypass local doctors and talk to high-powered consultants in hospitals over mobile phones. Patients might go onto the internet and check their symptoms and then negotiate with their doctors about the appropriate treatment. Both types of impact have been seen in the OECD countries over the last 10 years or so, and they're making an increasing impact in countries where there are much more limited resources, simply because of the reducing real cost of ICT hardware and software. So it's now commonplace to talk about mobile phones for $10, $15. There's a new smartphone being produced for $35. There's a $100 tablet last time I looked, though it may be less than that now. There's also convergence between these various types of gadget which people have, the mobile phone, the tablet computer and the laptop computer. So in the near future we will probably just have a mobile device which sells relatively cheaply and can fulfill all of these roles. As I indicated in the introduction, there are a very wide range of possible ways that ICTs might play a role in the health system. Perhaps the most important and least discussed impact is simply that people can now talk to each other. Obviously, patients can call up their doctors, doctors can call up their patients. A doctor can talk to colleagues, either to find out the history of his patient or to jointly decide the best course of treatment. The manager of a clinic that is running out of drugs can call someone up and order some more. All very simple, all very straightforward, but voice over mobile, as it's sometimes called in the literature, almost certainly has the biggest impact in improving health systems around the world. There's an increased ability to manage resources effectively, so you can computerize the purchase and distribution of drugs to your various facilities. Human resource management becomes much easier if it's all computerized, and if your health workers have mobile phones, you even know where they are at any given point of time. Drug tracking has become a very important activity to overcome the global problem of counterfeit and substandard drugs, so that there are a variety of mechanisms now. One, for example, which I've seen in Nigeria, is the use of a scratch card approach, whereby there is a strip on the side of a drug packet, much the same technology that you use to buy time on mobile phones. So you scratch the card, you use the number you find underneath to ring a central database and check the origin of the drugs and the distribution chain from that origin to your clinic or shop. The use of electronic medical records is an attempt to overcome one of the major problems in many health systems, which is that patients attending a facility essentially have no history. So the doctor treating them has no idea of their previous ailments, of the drugs that have been taken previously, of the detailed circumstances surrounding previous births in the case of a pregnant woman. Now, if you can maintain that information on a central database, either in a hospital or district office, then any doctor treating that patient can look back and make a much better determination of the most appropriate treatment. There are a number of international groups around the world who are very happy to make available all the software and expertise you need to set up one of these systems in any country. There are many initiatives now to provide remote consultation services, either doctor to doctor or doctor to patient, to help make a diagnosis. There are a wide variety of instruments to monitor treatment processes, heart rate monitors, blood glucose monitors and so on, which can be used, and then information passed to a qualified practitioner who can analyze the monitoring data and advise on the best course of action. A lot of countries around the world, often with donor support, have introduced remote data collection for routine health service information via mobile phones. Also used for disease surveillance, i.e. notifying outbreaks of some specific infectious or contagious diseases. There is also a huge volume of health information which is now available to the general public, either via their mobile phones or over the internet. Many NGOs and commercial companies will bombard you with SMS messages over your mobile phone. We'll cover this area in some detail in the next session. Finally, we have the dramatic increase in the scope of what I've called peer group communications. In the past, people with medical problems would talk to their family, their friends, contacts, colleagues, and so on. With the arrival of the mobile phone and the internet, the number of people you can discuss your problems with has grown exponentially. You can not only ring your uncle who's emigrated to the US, but you might even go onto Facebook and join a group of people with similar problems and discuss most appropriate treatments, how to negotiate with doctors and so on. There are now patient advocacy groups who follow the example of people living with HIV and AIDS, and in some countries those groups are becoming very powerful players in debates around the allocation of health resources. Given this astonishing range of potentially beneficial innovations, why should we worry about ICT applications? Well, I suppose at a very general level, we should always be rather wary of the technological fix. We've seen a number of breakthroughs in the past. We can think of the Green Revolution and more recently the use of GM crops as examples of innovations which were claimed to have the potential to greatly improve the lot of the poorest people, where the effects were much less predictable than originally assumed, influenced as much by political and social forces as economic and technological ones. The second concern is really around the idea of technological transfer. Many of these innovations have been introduced in highly developed economies where there is a long-established technological environment which can provide the support services which are often essential for successful interventions. When batteries run down, devices can be plugged into the mains electricity supply. When devices malfunction, there is easy access to expert technicians and a ready supply of spare parts. There will also be an adequate maintenance budget to meet the costs of these repairs, something which we often do not find in many countries where health budgets are much more tightly constrained. We should also be concerned that the successful application of ICTs in the health sector have usually taken place in relatively small-scale exercises, often in one health district, maybe in one urban area, and we should ask very serious questions about relocating or scaling up these exercises. Often those who are innovating in a given area put in a huge amount of resources and time to making it successful, and sometimes that is very hard to replicate when we try to operate on a larger scale or in different locations without those original innovators. With any technical innovation, we should always ask who controls the technology. Is it going to be purely market-driven? Will these interventions be controlled by the telecoms companies, for example, or the pharmaceutical companies? Will they be under tight government regulation? Will international donors and international NGOs be involved in the regulatory process? Will it be the Ministry of Health or the Ministry of Telecommunications which has the final say, or maybe the Treasury Department? All these actors have different preoccupations and perceptions of what is in their interest and in the national interest. So we need to be aware the way in which the intervention proceeds will depend very much on which actors are in a position to take the important decisions. I think there are particular reasons to be concerned about a technology which is so superficially attractive. I'm always astonished at the extent to which fairly intelligent politicians, officials and donors are influenced by the impressive demonstrations of ICT interventions. They seem to forget that it is very easy to put on a good show by controlling the environment and controlling the circumstances in which you try to demonstrate the effectiveness of the product. I was amused rather than shocked when I read this WHO survey in which a lot of senior health officials from countries where health resources were extremely thinly stretched, where hospitals were in decay, where rural clinics had shut down, all of whom thought that the latest electronic and ICT gadgets would dramatically improve the service that they could provide. The technology is also extremely attractive to staff. Often staff at a fairly low level within the health system. By being given, for example, mobile phones, learning how to use computers, they gain very valuable marketable skills. They also learn how to use email to communicate with their friends. They can get onto the internet and surf the web and so on and so forth. And this makes any kind of ICT intervention often very attractive to often lowly paid and sometimes disaffected staff members. We should also remember that we, the general population, are also strongly affected by the attractiveness of much of the technology, particularly, for example, the mobile phones. We're all seduced by the beautiful design, the colours, the keyboards, the displays, and so on, which have been both designed and advertised at vast expense to convince us of the value of the technology within. The empirical evidence on ICT interventions also gives some cause for concern. So fragmentation, lots of different and often very small scale interventions, lots of donors competing to put resources into their own small scale pilot exercises, unexpected and limited outcomes, failed and abandoned projects, the verdict of one reviewer. The third item there, you see it's rather dated, but I find it quite interesting because it's from one of the major public sector think tanks in the UK, which looked at developments in the National Health Service over a 10-year period and came to the conclusion that there was very little convincing evidence that ICT could deliver greater public value in health, even in spite of all the resources that have been put into ICT interventions in the health sector. And then a comment which has been made by very many people that most large-scale e-health implementations have little or no evaluation data. And the problem here, I think, is that the technology is developing so rapidly, that things change so fast, that people don't feel they have time to do a serious evaluation of outcomes. And they will often say that if technical problems have been identified, they can be simply overcome by updating the technology. Finally, in this section, just a few comments about what is usually described as the digital divide, the gap between the countries which have implemented ICT most aggressively and those which are, as it were, lagging behind. As you can see from this table, which is taken from the International Telecommunications Manual for 2012 and comparing that with the same manual for 2000, there has been fairly substantial growth in mobile phone subscriptions over that 12-year period, with some countries making the kind of progress you might expect. 7 per 100 in China in 2000 up to 81 per 100, and I would guess that's probably gone over 100 now in China. Similarly for India, but also for countries such as Bangladesh, where subscriptions had gone up to 63 per 100. Recent studies suggest that even in rural Bangladesh, between 75 and 80% of households now have a mobile phone. Though there are some countries where not everyone yet has a mobile phone. There's Malawi at the bottom of that list with about 30%, and I'll show some more on the next page. Note that we still have no very good way of measuring access to mobile phone services. Subscriptions are a very unreliable indicator because in most countries some people will have multiple subscriptions. So you can see the UK there, 135 subscriptions per 100 population. Even in a country like Cambodia, you'll find that people may have 3, 4, 5 SIM cards, because each SIM card manufacturer offers different incentives depending on the way you use their services. Much lower take-up of internet services in these countries. In Malawi, 4 internet users per 100 population. Bangladesh, even with its high level of mobile phone ownership, only 6 people per 100. 13 per 100 in India, which is perhaps surprising. China has pushed ahead with internet access in most small towns and cities, so 42 per 100 there. And just a final slide to note that one has to be careful about assuming that all countries have very high levels of take-up of mobile phones. It's not true. There are, in Africa, for example, some countries with rates that are higher than, for example, the UK or the US, partly because they have such terrible internal landline communications that people are kind of forced to take up mobile phones. But other countries, such as Malawi and Ethiopia down at the bottom there, where there is relatively low take-up of the technology, and one would assume that in poor rural areas of both of those countries the rates would be very low indeed.